Welcome, everybody. We're really excited to have Dr. Jeff Wardell here. He's an associate professor in the Department of Psychology at York University in Toronto, coming all the way from Canada. He also holds appointments with the Institute of Mental Health Policy Research at the Center for Addiction and Mental Health and with the Department of Psychiatry at the University of Toronto. So Dr. Wardell is the director of the Behavioral Alcohol and Cannabis Research Lab, or the BAC Lab. Great. You can visit their site at baclab.org. Check that out. They're interested in understanding the behavioral processes involved with substance use, blending the perspectives of clinical, cognitive, social, and personality psychology. Much of their recent work, Dr. Wardell is going to talk about, focuses on smartphone-based ecological momentary assessment methods to study psychological mechanisms involved in substance use behavior in real time. Some really, really cool stuff. And the ultimate goal of their work is to inform harm reduction interventions. Dr. Wardell received his PhD in clinical psychology from the State University of New York at Buffalo, SUNY Buffalo, and is a licensed clinical psychologist. He completed his postdoctoral work at the Campbell Family Mental Health Research Institute, the Center for Addiction and Mental Health in Toronto. He's very well known in the field of addictions. He served on the editorial board of Psychology of Addictive Behaviors and is a field editor for the Journal of Studies on Alcohol and Drugs. He has over 100 publications and has been well funded by the Canadian Institutes of Health Research and other funding agencies. So please join me in welcoming Dr. Jeff Wardell.
Thank you so much for that wonderful introduction. I'm really excited to be here today and have the opportunity to talk with you all about a program of research I've been developing over the past several years that focused on the intersection between medicinal and recreational cannabis use and understand the psychology motivations behind using cannabis for symptom management versus other reasons. And so I'm going to share with you some hot off the presses, recent ecological momentary assessment studies that were done that are gaining some new insight into this. And I am going to talk about a couple of key populations that we've been focusing on in my lab, which are people living with HIV and youth and young adults. And I'm going to start my timer here so that I don't run out of time. All right. So I'm going to start off by just acknowledging the sources of funding. A lot of this work is funded by the Canadian federal government. And I don't have any conflicts of interest to disclose or partnerships with cannabis industry. So what I want to actually start by doing is give a bit of an overview of the Canadian context for cannabis use, the policy framework that we found, because I realized I'm in a different country. And so just to set the stage for the context in which this work's being done. And then we're going to talk about medicinal cannabis use among people living with HIV in the context of legal access to non-medical cannabis, and go over the results of an EMA or ecological momentary assessment study with people living with HIV. And then I'll switch gears and talk about similar processes, but this time in a much different population, just young adults from the general community. And I'm going to wrap up with some conclusions and implications. So that's what we'll try to get packed into the next hour. So in Canada, in the early 1900s, we banned cannabis, and it was illegal for about a century. And that's similar to the US. We had very strict policies and attitudes towards cannabis. It was demonized as part of the war on drugs. And in the later part of the 1900s, there was growing pressure that cannabis be made legal for medical purposes. And so patient advocacy groups were really on the forefront of these efforts, including people living with HIV. And this culminated in the legalization of cannabis federally for medical purposes. So just over 20 years ago in 2001. And so at that time, it became legal for patients to access cannabis with healthcare provider authorization, so a prescription. And it was basically up to the physician to decide which conditions to authorize for. And there were many growing pains and issues with that system. And in the following 20 years, there was more advocacy and lobbying for increasing access to cannabis and shifting norms and attitudes towards cannabis, towards legalizing adult cannabis use for all purposes, so not just medical purposes. And so in October 2018, the federal government did do this nationally, and currently in Canada, a wide range of cannabis products can be legally accessed without healthcare provider authorization. But we do still maintain a separate medical stream where patients can continue to access medical cannabis products from licensed cannabis producers with physician authorization. So that's what the policies look like. What do rates of cannabis use look like? This data comes from the largest province in Canada, Ontario. And we have a long-running survey there that CAMH, one of the institutions I'm affiliated with, does. And so you can see that throughout the 80s and most of the 90s, the prevalence of cannabis, maybe I can get my pointer here, the prevalence of cannabis is kind of hovering around 10%. And then around the time that it was legalized for medical reasons, we see sort of a slow kind of gradual increase in prevalence. And then in the years leading up to non-medical legalization, we see a real shift in the trajectory, and prevalence rates have continued to go up even following legalization. At the same time, since 2018, when cannabis was legalized, we see that active registrations with licensed medical producers have declined since non-medical cannabis became legal over time. And this actually represents a very small proportion of the Canadian population that has an active registration with a licensed producer. So does that mean that Canadians are no longer using cannabis for medical purposes? Well, no, right? So our self-report surveys, so the most recent estimates we have from the Canadian Alcohol and Drug Survey, which is a nationally represented survey, suggest that 36% of people who are using cannabis say that they're using cannabis in part for medicinal purposes. So we have an increase in the number of people using cannabis, prevalence rates around 30%, decreases in people who are accessing it from licensed medical producers, but high rates of people who are saying that they're using cannabis for medical purposes. So there's really, this suggests that we have substantial self-medication with cannabis occurring outside of the healthcare context in this new regulatory framework. I'm just going to go through a quick fictional case example to illustrate why this might be. So here we have Jeremy, who's a young adult who reports severe anxiety and associated sleep problems, having very hard time sleeping. So he thinks he really needs some help to sleep and need to take something. So he thinks about it. He's thinking about going to his doctor and asking for something to help him sleep, but he's a little bit hesitant because he doesn't want to take tranquilizers or sedatives. He's worried about the addiction potential, the side effects of that. And then he remembers he has a good friend who told him that, marijuana can actually help with anxiety. You should really think about marijuana, and it has fewer side effects than other medications. So he's thinking, okay, maybe I should actually ask my doctor about marijuana and see if she would help me figure out how I could potentially use that for anxiety. But then he second guesses and he goes, she's going to think I'm some kind of a pothead. She's going to think that I'm, up to no good. I've never heard her mention anything about marijuana as a treatment for any other conditions or things. So, I'm not really sure that I want to go down this road. I don't want her judging me. And, come to think of it, I don't actually need her because I can just go to the cannabis store on the corner and, get advice from the experts, people who know about marijuana, people who are working in this industry. So that's what I'm going to do. So this is a bit of a contrived, fictional example, but I think it is illustrative of the types of things that anecdotally we're hearing from youth when they're talking about using cannabis for symptom management. So should we be concerned about this trend toward obtaining cannabis from outside the medical system for medical reasons? Well, maybe there's some theoretical reasons to think that it could potentially be risky. So if we look to the self-medication hypothesis, it's a long-standing theory for one pathway into addiction that suggests that when people are using substances on their own to cope with physical or mental health issues that they're experiencing, that this could put them at risk for substance use disorder. And there's a large body of research suggesting that coping motives for cannabis use and other substances are strongly associated with the development of substance use disorder. And for cannabis in particular, this might be the case that people who are using cannabis for self-medication, their risks for harms are exacerbated by just not knowing what to do. They're not getting proper medical advice. Maybe they're using higher risk product, combustible products, or they're using high potency THC products and not understanding proper dosing, the types of things that potentially a healthcare provider could help them with. So that could lead to increased risk for harm potentially. So is this applicable then to what we're seeing with medicinal cannabis in the context of legal non-medical access? And to understand this, we need to understand differences between those who do seek medical guidance and support with cannabis versus those who don't. One population that might be relevant to study is people living with HIV. Because it's one thing if a relatively healthy person uses cannabis occasionally to help with sleep problems that they might experience occasionally, but what about people with significant health conditions? Is self-medicating for them, what does that look like? And does it matter if they're getting cannabis through a healthcare provider or not? People with HIV are an important population to study. They've historically had high rates of cannabis use, and many are using cannabis to manage a wide range of symptoms like pain, appetite problems, medication side effects, but also mental health symptoms like anxiety, depression. So one question is, in Canada, now that anyone can access cannabis without healthcare provider support, are there differences between people living with HIV who do versus don't continue to access through the medical system? So just to provide a little bit of insight into this, I want to quickly summarize an analysis that a grad student in my lab recently conducted, Sophie Coelho, using data from the Ontario HIV Treatment Network cohort study, which is a large cohort of people receiving HIV care in the province of Ontario. And I'm just going to summarize some of the descriptive comparisons that Sophie did with this data set, because I think it sets the stage nicely for the EMA work that I'm going to turn to next. So what we did was we took the most recent data cut from this survey study that's done with a large number of HIV patients. And so we had data from 2022, which is several years after non-medical cannabis legalization. And we focused on the 868 participants who reported they used cannabis in the last year. And then we grouped them based on whether they were using cannabis through the medical system. So there was an item in the survey that asked, are you prescribed cannabis and are you using prescribed cannabis? And only 14% of the sample of people using cannabis said that that was true, that yes, they were prescribed cannabis and using prescription cannabis. So we compared those folks to those who were using cannabis but not prescription, quote unquote. And there is a typo here. This isn't the most updated version. It should be 14% of the sample reported that. I had to update that number, sorry. So how did these groups compare? Well, you can see here that the group of folks who were accessing and using cannabis from the medical stream are reporting much higher rates of daily cannabis use, but also higher rates of using non-combustible forms of cannabis like vaporizing and topical. But interestingly, no differences in using cannabis through smoking inhalation route of administration. In terms of their symptom profile, those who were accessing cannabis through the medical stream were reporting much higher HIV symptom distress, as well as poorer physical health and physical health related quality of life. So just to kind of summarize, there's a subset of people with HIV who continue to access cannabis through the medical stream. And it looks like they are more ill, they're reporting more symptoms. And so perhaps because of this, they're likely to seek medical provider guidance, that there's something that they're still getting out of working with a doctor or they're trying to access products that come from a licensed producer because maybe they think that those are better for therapeutic purposes. But whether or not their use is less risky than those who are self-medicating is a bit unclear. They're reporting that they're using non-combustible forms of cannabis at a greater rate, but they're also using much more often and much more frequently, likely because they're managing symptoms on a daily basis. But in any case, there's some suggestion here that the medical stream might still be serving an important function for a subset of people living with HIV in Canada, where they don't actually have to go through the medical stream anymore. One important limitation of these types of between-person comparisons, so between groups of people who use cannabis medicinally versus not, or who have prescriptions versus not, is just that there's blurred boundaries here. So an analysis I did on the same cohort prior to cannabis legalization suggested that a third of those who said that they're using cannabis medicinally said they're also using for recreational reasons. So it's not possible then to use between-person comparisons to distinguish between medicinal and recreational use behavior for a large portion of people living with HIV. So for this, we need to turn to within-person analyses to try to tease apart medicinal and recreational use among people with HIV who use for both reasons. Because it's possible that cannabis use behaviors and associated risks might differ within persons across the different cannabis use sessions, depending on their reason for use. So for example, a person might use a smoke-free cannabis oil product with lower THC and higher CBD when they get up in the morning if they're using that to manage pain. But then later in the day, if they go out with a bunch of friends, they might, use much higher THC smoked combustible cannabis when they're using for social reasons. And so these two very different cannabis use behaviors. So this led my research team to consider, can we use ecological momentary assessments to understand these within-person differences and to try to disentangle medicinal and recreational use among people who use for both reasons? So for those of you who aren't familiar, EMA is a widely used approach to studying substance use behavior in the moment, typically through administering surveys through a smartphone app, and people complete surveys while they're using substances. So it permits us to examine differences across individual cannabis use sessions and see if we can tease apart different motives for different sessions. And while several studies have used EMA to study substance use, including cannabis, among people with HIV, no EMA studies up to this point had used this to study medicinal versus recreational use specifically. So this was the goal of the Smart Hand study, which was a feasibility study that was funded by the Canadian Institute of Health Research Canadian HIV Trials Network. That's a mouthful, but it's basically an organization that funds HIV work that's federally funded in Canada. And the goal of this study, so we received some funding for a pilot study to just see, is it feasible? Can we feasibly use EMA to distinguish between medicinal and recreational use in this population? And the findings of this pilot study were published last year in AIDS and Behavior. I'm going to go over them now, but if you want to learn more, there is a paper out there that I'm happy to send you. I do want to mention that for the study, we partnered closely with two community members who had lived experience, and they were really integral members of the research team. And this was important because it helped us to ensure that the study was answering questions that are valuable for members of the HIV community. So I really want to give a special thanks to Sherry and Rico, who they're members of the Canadian HIV Trials Network Community Advisory Committee, and they partner on a lot of research that's funded by that organization. They did a lot of work for the study, including helping to even conceptualize the research question, all the way through interpreting and disseminating the findings, and they were co-authors on the paper. So for the pilot study, we recruited people living with HIV who were residing in Canada, and we were interested in looking at fine-grained patterns of cannabis use. So we focused on people who were using daily or near daily, so that we would get a lot of within-person variation in cannabis use behavior. And we targeted individuals who reported that they're currently using cannabis for both medicinal and recreational reasons. So we enrolled 29 people. The mean age was mid-40s. It was predominantly a gay white male sample, so there's some limitations there in terms of not having a lot of gender and racial diversity. And it also was a heavy cannabis using sample, so the participants reported using almost 30 grams of cannabis in the last 30 days. And about half reported that they had a valid authorization for medical cannabis. So some were self-medicating without physician support, and some were getting cannabis through the medical stream. Participants attended a baseline interview where we obtained informed consent. We did a timeline follow back of their recent use, primarily to actually train them in how to reliably report and estimate grams of cannabis consumed when cannabis flower was used, using visual aids and things like that, so that when they did the EMA, they would know how to do this. And then we instructed them to install an EMA app on their smartphone device. We used metric wire and provided them with a tutorial how to do this protocol. So here's what the EMA protocol looked like. So the participants did several types of surveys each day for a 14-day period. I'm going to focus for this talk just on the pre-cannabis and post-cannabis surveys. So participants first were told to go in the app, initiate a pre-cannabis survey every time you start a new cannabis session. And we define this for participants as using cannabis and after an hour had gone by since your previous use. This 1 hour time period was arbitrary, and really the only reason we chose it is we had post-cannabis surveys that happened an hour later, which is, we had a lot of discussion about the best way to do this. I'm happy to talk about how do you define a session, because my research group has lost a lot of sleep over this. The next EMA study I'm going to talk about after this one, we do it in a different way, but in any case, it's a whole can of worms. But basically, participants knew that if they had done a pre-cannabis survey, they're going to get a post-cannabis survey an hour later, report all the cannabis use that you did in that 1 hour period. Then if you use cannabis again after that, do a new pre-cannabis survey. So people were pretty mindful of that and understood what we meant by a session and how to go in and report these things. So the pre-cannabis survey, the main question we were interested in was just broadly asking about medicinal and recreational motivation. So we asked participants, why are you using cannabis right now? Medicinal reasons, non-medicinal and recreational, or both. They had those three options. And we did define for the participants, medicinal reasons were defined as using to manage or prevent any symptoms, regardless of whether they were prescribed cannabis for those symptoms. And then we asked about specific medicinal and non-medicinal motivations, or using now to manage symptoms, prevent symptoms, relax, socialize, celebrate, because we wanted to get a little bit more detailed understanding of their motives, as well as the current symptoms they were experiencing prior to cannabis use. And we had other measures on here too, but these are the ones I'll focus on today. So then, okay, so they do a pre-cannabis survey. An hour later, they get a notification in the app, do a post-cannabis survey. And so we ask them all about their cannabis use behavior during the session, the route of administration, the type they use, if they use cannabis flower, how many grams did you use, how high are you right now? And there was checklists of several positive and negative cannabis-related consequences that we got from the marijuana consequences questionnaire and other EMA research. Okay, so in terms of just getting a sense of feasibility here, we did have a large number of pre-cannabis surveys completed across the 29 participants for the 2-week period. So it was actually an average of 25 almost separate cannabis sessions that each person reported in that 2 weeks. They have a lot of data here for within-person comparisons. We had a lot of power for the within-person analysis, even though it's a small pilot. We also had a good compliance rate with the post-cannabis surveys. So 80% of the time, participants actually went in and completed that 1 hour follow-up. And 80% is kind of a benchmark that many people would consider good compliance in an EMA study. So we were pleased with that. And then the question is, okay, so how did these broad motivations break down? And what we saw was that about a quarter of the time, participants said, I'm using cannabis right now for medicinal reasons only. About 30% of the time, they said, I'm using cannabis right now for recreational reasons only. But then nearly half the time, they couldn't make that distinction. They said it's both medicinal and recreational. So remember, all the participants in the study engaged in both medicinal and recreational cannabis use. So there's some evidence that they do partially distinguish that sometimes it's one or the other, but a lot of times it's both. So that was interesting to us. So then what we wanted to do is we wanted to look and see how did these different cannabis sessions differ in terms of specific reasons for use, symptoms, these kinds of things within person across sessions. So we conducted multi-level modeling to examine the within-person differences. And so we had sessions nested within participants. And at the session level, we had two contrasts. We had recreational only sessions as our referent category, and we compared the medicinal only and mixed motive to recreational only. We controlled for between person differences in the proportion of each of these sessions, because maybe some of these things are driven by the fact that some people always use for medicinal only and recreational only, so we wanted to account for between person variance. And so we examined a number of outcomes. Binary outcomes were, we used a logistic link, log link, and for linear outcomes, it was a Gaussian distribution. And we also covariated for age, gender, and race. Okay, so why don't I jump into some of the findings? So here I'm showing the specific reasons for cannabis use endorsed on the pre-cannabis survey, broken down by whether the participant broadly labeled the session as recreational only, so that's the gray bar, medicinal only is the bright red bar, and mixed motive is the maroon bar. And here I'm just showing the raw percentages of each type of session where each reason was endorsed, but the asterisk denote whether the within person comparison to the reference category of recreational only was statistically significant in the multi-level model. So what you can see is that when participants reported that they were about to use cannabis for medicinal reasons, or both medicinal and recreational, they were more likely to report that they were using cannabis specifically for symptom management and preventing symptoms. However, the mixed motive events were uniquely associated with greater likelihood of endorsing negative reinforcement reasons like to be stressed or calm down or to feel normal. And we didn't see the same difference for medicinal only relative to recreational only. Further, the medicinal only events were less likely to involve cannabis use for relaxation, happiness, or wellness relative to recreational only events. So these were sort of uniquely recreational reasons for use. And there were some specific reasons that we gave that just weren't highly endorsed, and so we didn't have the ability to actually examine them in the multi-level model. So we didn't get a convergence in those models. I have those marked with the dagger here. In terms of symptoms reported on the pre-cannabis surveys, medicinal only and mixed motive events were associated with much greater likelihood of reporting physical symptoms such as pain and nausea, as well as insomnia relative to recreational only events. And in contrast, the mixed motive events were uniquely associated with greater endorsement of mental health symptoms, oh, there's my pointer, like anxiety and depressed mood. In terms of cannabis use behavior reported on the post-cannabis surveys, participants were less likely to report using cannabis flower and more likely to report using oils and sprays when it was a medicinal only reason for use relative to recreational only. But we didn't see differences in the other ones. Again, we didn't have a lot of observations for these other forms of cannabis. The routes of administration were showing a trend towards less smoked cannabis and more oral cannabis routes used with medicinal only, but it didn't reach statistical significance in the multi-level model. So one thing that's interesting is when participants said they were using for a medicinal reason, either mixed medicinal and recreational or medicinal only, they're actually reporting using fewer grams of cannabis flower that's specific to mixed motive, or being less high, that's just specific to medicinal only, relative to recreational only. And finally, the likelihood of reporting one or more negative cannabis consequences on the post-cannabis survey did not differ across the event types, but participants were less likely to report one or more positive consequences on the medicinal and mixed motive events than they were on the recreational only events, which was interesting to us. Yeah, questions?
Positive consequence.
So we used consequence consequences from past EMA research, as well as our people with lived experience advisors helped us develop. So we had things like, I felt a sense of wellness, I experienced creativity, or I wish I had the list here. I felt a sense of relief from my symptoms was one of them. So it's kind of positive things that we would expect people. It wasn't a standardized measure or anything though, so there's some limitation there that maybe we had a biased assessment of consequences there, but yeah, does that answer your question?
Yeah, absolutely. There's people, and maybe there was a 1080 too, because I would not like it's some surprising, like the medical use might have a lower like delete from symptoms. So
Yeah.
have a 1080 is at this.
Yeah, so I think some of the items were maybe more geared towards things you would expect to be positive about recreational use, because it did say things like it helped me feel better and about myself socially or something like that. So I think I'll get those items for you because I actually think that's an important observation.
Thank you.
So just to wrap up the findings from this study, so I think this provided us with some really interesting data to suggest that EMA is a feasible approach for disentangling medicinal and recreational cannabis use at the event level among people living with HIV who use cannabis for both of these reasons. Some events were purely medicinal and some were purely recreational. They weren't always both, so they are making some distinction. But it's important to recognize that nearly half of the events, they weren't making a distinction, so it wasn't possible to fully disentangle medicinal and recreational use. So I think this suggests that we have a need to move away from discrete labels, categorizing things as, medicinal or recreational as if they're sort of separate categories, and thinking about this more in a continuum, and other researchers have talked about this as well. We did find, though, that there were significant differences between the medicinal and recreational events. So they looked different in terms of the antecedents, cannabis use behaviors, and immediate outcomes. Oops. So one thing that really distinguished the medicinal and mixed from the mixed events was mental health symptoms and negative reinforcement motives for use. So things like people clearly label the management of physical symptoms as medicinal use. It's medicinal only. But there was more of a blurred boundary when it came to the mental health symptoms like anxiety or depression. They weren't sure if it's medicinal, recreational, or both. It also looked like people with HIV use potentially lower risk products like non-combustible oils and sprays when using specifically for medicinal reasons. And they also reported being less high and using less quantities when there was a medical component to their motivation, but no differences in negative consequences. So it's not clear that there's a big difference in terms of level of risk between medicinal and recreational use events, at least for acute negative outcomes that we assessed. And again, it wasn't a comprehensive, fulsome assessment of all potential negative outcomes. So that's a limitation. Yeah. Yes.
So the cannabis oils and sprays, are those psychoactive?
They typically are containing THC, yes, although some of them may have been CBD dominant, but they can be. They can be actually high potency THC, some of the products that are available on the market. This is actually the limitation, is that we didn't know what the cannabinoid content of any of these products was. So this is probably by far the greatest limitation of this pilot studies. We don't know exactly what's in what they're using. Now, the next study I'm going to present, we try to do a better job assessing that. So maybe I'll have some data that speaks to your question. Do you have another question?
Just in Canada, in terms of the medicinal cannabis and recreational, are they sold in different places, or is it like how does?
Yeah, so there is a medical stream where through a physician you can get authorization to register with a licensed medical producer and get medical products. The thing is that those products are available on the recreational market too. I don't know how different the products are. And so, yes, a lot of people are just going and getting a CBD oil from a cannabis store. And maybe there's some THC in it, maybe there's not. So it's not that distinct actually in terms of the products people are getting, from my understanding. I haven't looked into it recently though.
Okay, cool, very cool.
Good
It's
question.
interesting to like compare what's happening here in California and because the medical licenses and recreational licenses are completely separate.
Right.
Given Star cannot sell the medicinal cannabis and
Yeah,
recreational.
and in Canada, that's true too. They're not supposed to claim these things can be used for medicinal reasons, but they're still able to give you an oil that looks like a medicine. It's got a little medicine dropper and
Yeah.
right, and these are sold in recreational stores.
So there's this like are people going to recreational stores and using for medicinal?
I think absolutely, yeah,
versus-
yeah, absolutely. And that's the question here, right? Does that matter? So yeah, very good question. Okay, there's other limitations I'm not going to talk about for time's sake. There's always limitations. It was a small pilot study, so I don't want to overemphasize the generalizability of the findings. And then especially this post-cannabis survey, it was 1 hour later, so there's also not good coverage of the post-cannabis period, especially if people are using through oral routes of administration, maybe the effects take longer to have their onset. But in any case, one strength here is that EMA actually has a lot of strengths through reducing recall bias, giving us rich with in-person data. So we were encouraged by this. So much so that, this pilot study really gave us some interesting insight that led to my next study where I wanted to see if these same processes and distinctions between medicinal and recreational use, what does this look like in an entirely different population? Youth and young adults who are using and self-reporting medicinal motivations for use. Because this is happening. So in Canada, our estimates are from epidemiological surveys suggest that about a quarter of adolescents and young adults who say that they use cannabis are reporting medicinal reasons. And the items that get at this differ in different surveys. So sometimes it's to manage symptoms of physical and mental health. Sometimes it's for medical purposes. Specifically, they use that language. And we're getting about a quarter of young people saying yes to this question, which I was actually surprised by when I started analyzing some of this data. And when you look at surveys that are administered to non-clinical samples of young adults who use cannabis, you see that they're reporting using cannabis for a range of symptoms. So it's not just things like anxiety and sleep. They're also reporting using for pain, using for GI symptoms, headaches, right? So similar symptom profile of what we saw for people living with HIV, the same symptoms that clinical populations are using cannabis for. But importantly, the vast majority of young people who are using cannabis to manage symptoms in Canada are getting it from outside the healthcare system. This is a much higher proportion of people than our clinical samples, like people living with HIV. So they're essentially self-medicating. And they might be at risk because there's a lot of misinformation out there, and they're young, they're impressionable, they're on social media, their brains are still developing. So this is a population I think that we need to be particularly interested in looking at these processes. And I just wanted to show this is an actual advertisement outside a cannabis store down the street from where I live. Students save big on cannabis, bring your student ID and you get a 10% discount. So they're checking IDs at the cannabis store, just not, not the way you would expect, right? So this is something that's happening right now.
Is the age for purchase 21 or 18?
It depends on the province. Most provinces are 18 or 19. Quebec actually has 21. They recently raised their legal purchase age. And I can get into the whole politics about that if you have a question. It's a bit tangential.
And sorry, for alcohol, is it 21 or 18?
It's 18 or 19 in all provinces, yeah. Interestingly, Quebec has the highest cannabis purchase age, but the lowest alcohol purchase age of 18. So you can get alcohol when you're 18, but you got to wait 3 years to buy cannabis. So go figure. Okay, so this brings me to the next study where we wanted to better understand what medical cannabis use behavior looks like in this population and how it differs from non-medical use. So I recently received a new grant from the Canadian federal government to conduct a similar EMA study with young people. And we have a really great team of co-investigators. who have contributed a lot to the development, and we're about to launch data collection this fall. But we did complete a pilot study that informed the development of the grant, so I'm going to present some hot off the presses pilot data from this study. The pilot study also had the additional aim of examining the feasibility of using EMA to capture THC and CBD consumption in standard units, because this is a limitation of prior work. So they're being called in the literature for observational studies to do a better job of assessing this. And many people are sort of getting behind this idea of a standard THC unit being similar to a standard drink for those who do alcohol. And that's been defined as 5 milligrams of THC. And some self-report methods for capturing standard THC have been published recently, but none have been applied in EMA work to my knowledge. So this was something we wanted to look at in the pilot study. And for the pilot study, we received some internal funding from York, as well as a student award from the Canadian Psychological Association. One of my graduate students got for an add-on project in this pilot study. So for the pilot study, we recruited young adults from the community. We had a really broad age range for young adulthood in this study because we wanted to be as inclusive as possible. And also just for feasibility, we wanted to try to recruit a sample quickly, and we didn't want to be too narrow. And we were targeting folks who use cannabis products with THC quite frequently, because again, we wanted multiple sessions per person. We didn't just want one session. And they had to report using 2 different forms of cannabis weekly, and this was to get at whether they can report THC and CBD across different types of products. And we also required that they said they were using both medicinal and recreational reasons. So we just recruited from the community. We just had online ads, flyers on campuses. We reached out to youth partners to help recruit. So it wasn't a patient sample. And interestingly, I was really worried about recruitment, but we got a good response. We got our pilot, our target, and a 40. In fact, we actually went a little bit beyond. We got 42 people enrolled in I think I was doing it for about 6 months or so. And then the design of the study was similar to the one I just presented in terms of they did an online one-on-one Zoom, getting a tutorial where we taught them how to do the EMA, and we trained them how to report the THC and CBD from their products, where to find the information on the label. And so that was kind of an involved process. Oops. Then they did 14 days of EMA, and the design was a bit different. Instead of post-cannabis surveys, we just had surveys throughout the day. So morning, afternoon, evening, and bedtime. And so this way we were able to kind of look at how does cannabis reported on a pre-cannabis survey relate to outcomes reported at various points throughout the day. And so we're kind of trying to standardize the follow-up assessment here and not make it time-based, but more so that we can kind of get a broad picture of what's happening all day long. So participants were told, initiate the pre-cannabis survey before you're about to start a new session. This time, we had youth with lived experience on the team here too, and we consulted with them quite a bit. And we decided to allow a bit of subjectivity in defining a session. So we told participants a session is defined as a continuous cannabis use without taking a meaningful break. And then we kind of left it up to participants to decide what that meant for them. And this was important because early versions of these kind of time-based session definitions, people were saying, well, that doesn't really apply. I'm vaping, well, if I vape, have 3 hits here and then wait 15 minutes and have 3 hits, is that a new session? And we realized that for the design of the site, it doesn't really matter. As long as they're doing a pre-cannabis session every time they are about to use cannabis, if they think it's a new session, we want to know what their motives are for use. So again, there's pros and cons of this, but this is what we landed on for this study. The other thing that we did for this study was, okay, we don't want categorical medicinal or recreational motives. So we tried to measure this dimensionally. We had 2 items. To what extent are you motivated by medicinal reasons to use right now, 1 to 5 scale? To what extent are you motivated by recreational reasons? So we wanted to see if these things were separate dimensions. And we did define medicinal reasons, again, for them as using to prevent or manage physical or mental health symptoms, regardless of where you get the cannabis. And then we asked about specific reasons for use, symptoms that you're currently experiencing. Also on the pre-cannabis survey, we asked them, report the cannabis you're planning to use in this upcoming session. So tell us the type you're going to use, where you got it, how much you're going to use, and what's in it, the THC and CBD. And we actually, this was, the information that we collected on the EMA was designed to help us calculate these standard THC units. And the feasibility of doing this is something we examined in a paper I'm not going to present, because I don't want to steal the graduate student in my lab's thunder who did all the heavy lifting here, Sophie Coelho. But I will just say, I will talk a little bit about how we got that data and present on how much THC and CBD they were reporting. So one thing we did to establish feasibility is we said, okay, for the cannabis you're about to use, did it come in a package with a label? Right? And if they said no, we didn't ask them to report the THC CBD, because how would they know if they were growing it themselves or getting it from an unregulated source? If they said yes, we said, okay, tell us how much THC and CBD is in there. Then we asked them, do you have the package with you right now? If they said no, we asked them, okay, how confident are you that you reported this correctly? And if they said yes, we said, okay, snap a photo. And this is an example of an actual photo we got from a participant. And so then what we were able to do here was compare what they typed in to what's on the label. For the most commonly used products of flower and vapes, about 3/4 of the time they said, yes, it came in a package with a label. And then of those, half the time they said, I have the package, and they took a photo. So the biased sub-sample of the sessions that we have the photos for. But for those sessions, there was actually quite high agreement between what they typed in and what was on the label, giving us some confidence that they understood how to report these values, where to find them on the label, knew what we were asking. We made them do some mental math. Sometimes a range is reported, so we told them put the midpoint in. They did a good job doing that. So there's some ability for participants to actually do this, at least when they have the label right there. Which, you know, seems intuitive, but you never know with young people, like, you know, the label's right there, but what are they actually putting in? So we enrolled 42 participants. The majority were female and also white. We did have some gender diversity in the sample, which is interesting. Probably had to do with some of the youth organizations we reached out to. Medicinal cannabis use was reported by everybody. They said they were using for medicinal reasons, and greater than 80% said they were using to manage a mental health symptom like anxiety, stress, or depression. But we also saw a high endorsement of other symptoms, including physical symptoms such as pain and nausea. And 14% reported that they had medical cannabis authorization through a healthcare provider. So it's not entirely self-medication, but it's still predominantly so. We had good compliance with the EMA. I was shocked by this because I've done EMA studies with young adults before, and it doesn't look like this. So there's something about this population that was different, I think. They were really motivated to help us get this data, the people who we enroll. And we had a lot of pre-cannabis surveys again. There's only 42 participants. We have almost 800 separate cannabis sections to work with in our multi-level model. So the average participant reported 18 different sessions across the 2 weeks. What were they using during these sessions? Predominantly cannabis flower and vape. Some edibles, less than I would expect. Again, it's a pilot sample, so it's not necessarily generalizable. In terms of the THC and CBD that they reported, when we were able to extract that data, high amounts of THC. So the daily average THC consumption was 113 milligrams of THC and only 4.5 milligrams of CBD. So they're using high potency THC products much of the time, and CBD doesn't seem to be factoring in very much in this sample. Here are the dimensional items assessing medicinal and recreational motives. And you can see that they look kind of normally distributed. So there, it does seem like this is a continuum. Sometimes it's not at all medicinal, sometimes it's extremely medicinal, but sometimes it's somewhere in between, same with recreational. And the interclass correlation coefficient suggested that the majority of the variance in these items is within person. So it's not that the same people are always saying it's medicinal. They're varying in the degree to which it's medicinal and recreational across days, across sessions. So that's interesting to us. There is within person differences here. And while these two items were strongly negatively correlated, when you square the correlation coefficient, only about 36% of the variance is overlapping. So that suggests that they are separable dimensions as well, and they might uniquely relate to outcomes. And I realize I'm short on time, so I'm going to blast through a couple of hot off the press things so I can talk a bit about implications. But we did these multi-level models. We wanted to see how do these two items, medicinal cannabis, the continuous item, and recreational, how do they uniquely relate to specific reasons for use, symptoms, et cetera. So we did multi-level models. We person-centered these items. Each session was nested within participants, and they were entered simultaneously as predictors. We also had between person variance on level 2, but no other covariates because these are just preliminary. So what we found was that greater event level medicinal motivation was significantly associated with greater likelihood of reporting using cannabis for symptom management, and also some negative reinforcement reasons like reducing withdrawal, de-stressing and calming down to feel normal. But really the reducing and preventing symptoms had the highest odds ratio. This is what's most strongly associated with this medicinal item. They were also more likely to report experiencing a range of symptoms. The odds ratios were all within the same range. So how to interpret this is for every 1 unit increase in the medicinal cannabis use item during a given session, there was about a 1.4 to 2 times greater likelihood of endorsing these symptoms. There was also a 2 times greater likelihood of endorsing using cannabis oils when they were higher on the medicinal spectrum, but no association with the amount of THC or CBD consumed. In terms of the recreational item, we see that this is not related to reporting using cannabis for symptom management reasons, although there was this relationship with negative reinforcement motives again. So again, both medicinal and recreational motives seem to relate to these kinds of negative reinforcement reasons. But the strongest relationships were with the things we think of as recreational, socializing, having fun, feeling happy. Very little relationship between this recreational item and symptoms, either in a positive or negative direction. So it really was the medicinal item explaining variance in symptoms, interestingly. Depressed mood was the only exception. And it was predictive of using cannabis flower, whereas the medicinal item was predictive of cannabis oil. Again, no associations with THC or CBD. And then very quickly, days with relatively greater recreational motives were associated with greater negative consequences and greater positive consequences. Oh, it is. Is that my time is up? That's the bell telling me. But no association with the medicinal motive item and consequences at the day level. So to quickly summarize, again, I think these pilot data are telling us EMA is feasible for helping us disentangle broad medicinal and recreational motives, this time among young adults. And what we found was that momentary medicinal and recreational motives were differentially linked with specific use, reasons for use, current symptoms, and type of cannabis use. So there's differences here. Maybe I'll skip the discussion about what this means for self-medication, because I think the answer to this is we don't know yet. It doesn't seem like in the moment, if somebody's specifically motivated by self-medication reasons for use, that there's any additional risk related to that motivation. But this is, again, a small pilot study, and so we need to replicate this with a larger sample, which is what we're going to do with the bigger grant that we have now. And so what we're hoping to do is scale this up, recruit a larger, more diverse sample, look at between-person moderators, like specific symptoms and conditions, look at differences based on medical authorization status, and yeah, and there's other limitations. And then the last thing I'll say, I promise, I know I'm packed a lot. I'm known for trying to do too much in too little time. I think that this work has some research implications. And I guess the message I want to send is if you're doing cannabis research, even if you're not doing medical cannabis research, you're working with clinical populations, you should probably be assessing medicinal motivations for use. Because especially with young people, they're reporting this use and it looks like it's associated with different behaviors. And then, of course, we need to do a better job assessing THC and CBD and EMA studies. I think there's some policy implications. I was talking about this morning, that there is a debate about the future of the medical cannabis use system in Canada now that it's legal. So some people are calling for getting rid of the medical cannabis system. Why do we need it? People can get it legally. We don't need doctors involved in this. But some patients are saying, wait a minute, I need my doctor to support me. I need this medical guidance. This is a medicine for me. So I think maybe the results are suggesting that cannabis use is not cannabis use is not cannabis use. There might be differences between medical cannabis and recreational cannabis use motivations that suggest that separate streams make sense in some cases. And then, of course, I'm really hoping this work will inform clinical implications in the future, helping us to develop better ways of supporting patients and young people who are using cannabis for symptom management, providing tailored guidance about their use from a harm reduction perspective. And they still get some therapeutic benefit, but minimize harms. Well, maybe this is about helping to understand, distinguishing a little bit their medical use and their recreational use, and choosing products and things that make sense for them. Okay. So I do want to just acknowledge my whole team, all my collaborators, everybody that helped do this. I get to stand up here and take all the credit for it as a single individual, but it takes a village, and I couldn't do this alone. And here are a bunch of students in my lab. This photo was taken at the recent Research Society on Marijuana conference in Toronto, where we were presenting all of our cannabis work. They're doing amazing stuff. They're a great team. And yeah, I guess I'll leave it at that. I'm happy to take questions.